Anyway, this is a new initiative by KGMOA that you're taking up academics in a big way, which is again commendable. So we'll move ahead with the presentation. The organizers have given me 1 hour, so let me finish in 15 minutes. My apologies in advance because I'm having some connectivity issues. So if I get disconnected from my Wi-Fi, I'll go back to my mobile tethering. So you should give me a bit of time for that. Let us hope that that is not needed and doesn't happen. So as we already discussed, World TB Day slogan remains that we can end TB, and it is led by countries, powered by people. It's more applicable to Kerala, where people's involvement and community involvement TB is much more than any other state of India. In fact, many states of India learned from the Kerala model on that. So in this presentation for the day, even though the focus was on differentiated care, I will discuss a bit on the basics and build on to why we need differentiated care and how that has been implemented in other states and probably can be properly implemented in Kerala. So a bit on the diagnostic and treatment algorithms, and then what is missing in that, what is needed more, and then go on to differentiated care. So as we all know, TB still remains a major public health problem for the world, as well as for India. So if you see most of the places, it's incidence, mortality or MDR TB, we have more than 1/4 of the global burden. In fact, MDR, we have 1/3 of the global burden, which is not a very happy place to be in. But then our efforts become very important. You and I become important because, as Westerners often used to tell me during my WHS, if India controls TB, the world controls TB. So our contribution is crucial to the world efforts to controlling or eliminating TB. But our challenge is also that we have big numbers of TB patients, and it's a tough ask for all of us. Moving on to the diagnosis. Not in diagnosis. So when I started working in the health service department and was posted as a district TB officer, please tell me if I'm not audible because I'm. You start with something called presumptive pulmonary TB for pulmonary tuberculosis, which included cough more than 2 weeks, fever more than 2 weeks, significant weight loss, hemoptysis, and any lesion on an X-ray. Currently, with the differentiated care document, these 4 symptom screening, which we used earlier, has changed. And now you actually use a 10 symptom screening. I wanted to put a slide on that, but I forgot. So you have more symptoms added, including chest pain, breathlessness, presence of lymph nodes, and other things. So anyway, pulmonary TB, the main things you're looking for is cough more than 2 weeks and fever more than 2 weeks. And such people, you have to immediately do a smear examination and an X-ray. Earlier, we used to do a smear, do a repeat smear after 2 weeks of antibiotics, and only then take X-ray. But now the X-ray and smear has come together. And as per the algorithm, this has to be done. But of course, when we implemented this for the first time in Kerala, we found that it was not very easy for us to take an X-ray. Doing the smear was easier because even if a microscopy center was not there in that particular PSC, we could actually transport sputum specimens and all that. But for X-ray, the patient has to go. And X-ray was our major challenge. In any case, if smear is positive, you start treatment. And if smear is negative and the X-ray is suggestive of TB, you have to do a nucleic acid amplification test. Now, even the smear positive patients, as part of the universal DST, have to do a nucleic acid amplification test, so that finally everybody ends up getting a nucleic acid amplification test done. So basically, even from the beginning, special groups like maybe someone who's pregnant or someone with presumptive MDR TB or somebody with, say, HIV would directly go to a nucleic acid amplification test. Where we have gone ahead is that you have something called upfront NAT, where a person who is a presumptive TB, you don't even have to wait for an X-ray or a smear. You can directly do a TrueNAT or a CBNAT and then go ahead with a diagnosis. In Kerala, Trivandrum district is now 100% into upfront NAT. So that in Trivandrum district, for diagnostic purposes, no smear AFB is done. Smear is still done for follow-up, but all diagnosis of TB in Trivandrum district actually occurs with the upfront NAT, and the NAT is the first go-to test. But that always leaves a problem that often X-rays are left out, and X-rays are often needed not just for diagnosis. It also helps us to know the extent of the disease and some other complications in patients. So as far as possible, it is desirable that a chest X-ray is also taken for our patient. Moving on, just before I move on to the next form of TB, just one case, which is a repeatedly occurring scenario in many parts of Kerala. Am I audible? I'm sorry for the network issues. If it gets disconnected again, I'll go back to my mobile network. Is it visible again?
Kanam, sir, Kanam.
Okay, thank you.
Kanam.
So this 50-year-old man who came with was a smoker and alcoholic, came with all symptoms which suggested presumptive pulmonary TB, and a smear was done in that particular district. At that district, I assume that had not gone to upfront NAT. So that a smear was done and the smear was negative. This was sometime in October. You may not be able to see the date at the bottom. This was sometime in October. But later, after a couple of months in December, this patient comes to a medical college where X-ray is done. You can see the bilateral extensive disease. The right side is almost completely destroyed, and the left upper lobe is also almost fully involved. At this point, obviously, a NAT was done, and the NAT came as 2.8 into 10 raised to 6, which indicates a high load of bacteria. So this is worrying for us clinicians because the disease has become so extensive that this patient's prognosis in the long run is bad. And it is also worrying for the public health doctors because there is such delay in diagnosis of 2 months, even after a patient was symptomatic for 1 month. So about 3-4 months of delay results in so much of spread of TB. So this is something that we need to prevent. It is not just enough that you diagnose TB. You also have to diagnose TB as early as possible, which leads to better treatment outcome for patients, short term and long term. It also leads to lesser spread of TB in the community. And also it reduces to lesser mortality, which is something that we are the theme of the discussion today. Moving on to extrapulmonary TB. Now, extrapulmonary TB, it's not very easy to define a presumptive extrapulmonary TB because any organ in the body can be involved, and the features may be, may depend on the organ involved. If it is in the eye, you may have redness of eye and, defective vision, or if you have something in the brain, you may have all features of a space occupying lesion in the brain. So all such features will be there. So based on that, in any organ, you have to keep an active watch for extrapulmonary TB. More important in Kerala because about 34%, 35% of our TB is extrapulmonary TB. And the number is on the increase. So, Kerala has a higher proportion of extrapulmonary TB and you have to be on the watch for it. In fact, again, a study done by a PG student this year was looking at differentiated care. And we found, for example, in one district, patient who had a fall from a stool when he was putting up something. And when he fell down, he went to the nearest hospital where he was given just analgesics. So, he was not really evaluated. And then the pain did not subside and he went to a private hospital where he actually got a MRI done and they found that it was a spinal TB. So the point I'm making is that, unless we are alert, you might associate that pain or, any of those features with something else. So always keep that in mind. Now, once you suspect extrapulmonary TB, the main question to ask ourselves is a sample available for me for testing? So not every form of extrapulmonary TB, you may have a sample. So for example, a tuberculoma in the brain or a spinal TB, you may not have a sample available. And if a sample is not available, and the clinician and the radiologist and the entire diagnostic team is sure this is TB, they are allowed to treat with a diagnosis of clinically diagnosed TB. However, in most forms of TB, you will actually have a tissue available, in which case, you have to do a NAT, a histopathology, and in some of the samples called precious samples, you may do a culture as well. So, the precious sample, when I say that, I mean like a tuberculoma in the brain. If a surgery is being done, you may not get another opportunity to do one more surgery. So there, that sample becomes precious. So if it is a single lymph node and you take the node out and then you need to do further analysis, you may not have a node available. And if you feel it's crucial to know resistance in that pattern, in that patient, then you actually should send for a culture as well. So for NAT and culture, the important thing in extrapulmonary TB is to send it without putting in formalin. So one specimen has to go in for histopathology in formalin, and one specimen has to go without formalin for your microbiological examination. Often, the surgeon would be busy doing the surgery. The sample is given to the nurse, and the nurse would immediately put the entire specimen in formalin so that then you can't do any of the microbiological tests. Now, if your NAT or culture is positive, you call it microbiology confirmed TB. We should understand that despite doing NAT and culture and all, a small percentage of your extrapulmonary TB may still be negative on these tests, even when they have TB, and histopathology or radiology may be the only diagnostic test. So there you again call it as clinically diagnosed extrapulmonary TB. The only thing to remember is that we are trying our best now in the program to ensure that the maximum number of extrapulmonary are microbiologically confirmed extrapulmonary TB, so that you have to send a NAT. It should not be that you're not send a NAT and then you have made a diagnosis. If you have made an attempt and then it is negative, that's fine. No issue in that. So we actually checked what kind of, diagnostic modalities are used in our regular setup. So the study was done by the microbiology, pathology, and pulmonary medicine team in Thrissur Medical College. So if you look at it, even today, the higher proportion of patients actually undergo a pathological evaluation rather than a microbiological evaluation. So microbiological evaluation is done only in a smaller proportion of patients, but wherever microbiological evaluation is done, the yield is fairly good, 78% for lymph node, 70% for skeletal and all that. But the problem is that because samples are not sent, you can see that the yield often is much lower because the sample was not sent. So you can see here, like for suppose all the lymph node TB had undergone a NAT, we would have got 78% positivity on microbiological confirmation. But since NAT was not sent in a significant proportion of patients, you only have a 31% positivity. So that is because the samples are not sent, not because the test does not give you positives. So our attempt should be to send NAT for all our patients. Now, just again highlighting that one point. So, we had this elderly man who was the father of a surgery professor in my college. So he had intestinal symptoms, weight loss and all. So it's all, could be a presumptive intestinal TB, but the clinical suspicion at that time, elderly man was CA colon. So colonoscopy was done, a lesion was seen, biopsy was taken, but as usual, only a histopathology was sent, which came as caseating granuloma. There was no malignancy. So now this gentleman and son, the professor, came for treatment. So I explained to the doctor and the father that ideally I would want a NAT also to be done. One, to confirm that this is TB, and secondly, to know the resistance pattern, to know that I am giving the right drug. So I expected that, the father, elderly man would say that I don't want one more colonoscopy. But to my surprise, he and son both said that if that is the right way of evaluating, we will take one more specimen and evaluate. So they went and did one more colonoscopy. Now, because it's medical college, it's all free. But of course, it is affordable for them, even if they wanted to do one more. And they actually did a colonoscopy. The sample was sent for NAT. Here I got MTB detected, refluxes not detected. So I'm sure of my diagnosis of TB, as well as know that I'm giving the right drugs for a drug-sensitive TB in this case. Now, of course, the more and more knowledge is there in doctors treating extrapulmonary TB. We need to, further increase that knowledge base. So here you have a liver with small nodular lesions, very small, not so clearly visible. But then the gastroenterologist went ahead with the FNAC from those lesions, guided FNA, ultrasound guided FNA. And the CBNAT showed MTB detected, refluxes not detected. So a diagnosis of TB could be easily made. Earlier, such patients would be going here and there until a surgery was done before diagnosis. Of late, just a FNAC, guided FNAC with a NAT gives you a diagnosis and the patient gets immediate care for his disease. Now, in addition to diagnosis, you in the program guideline, you have something called an integrated algorithm, which covers both diagnosis and treatment. And you have various treatment regimes. And to reach these treatment regimes, you actually need to know the resistance pattern. So, the days when I was young and I was teaching MBBS students, I would say that, if I was in the US of A, I would have done sensitivity pattern to about 14 drugs and then guided the treatment for that patient. In India, I'm not able to do that. But now, today, I'm so happy to say that even in India, we are doing sensitivity testing and we are doing a guided treatment based on the sensitivity pattern for most of our patients. So, how we do that is called the Universal Drug Susceptibility Testing, or the UDST, where NAT is done for all TB patients. So, like I said earlier, for example, Trivandrum district, NAT is the upfront test for all patients. So, anyway, patients undergo NAT, and when they undergo a NAT, with the NAT, either it's a true NAT or CB NAT, you also get a rifampicin resistant status. So, in other places where if smear or other tests are done, a NAT should be done as an additional test to actually do this resistance testing. So, once you do a nucleic acid amplification test, you get either rifampicin resistance. If you get rifampicin resistance detected, then you actually have to do follow-up evaluation with the first line probe assay, which will actually give you resistance to INH, rifampicin, and ethionamide, and a second line LPA, which will give you resistance to fluoroquinolone and second line injectables. And you also do a MGIT or a liquid culture, which will give you sensitivity or resistance to linezolid, clofazimine, pyrazinamide, high dose moxifloxacin, and the newer drugs, bedaquiline, delamine, pretomanid, and all. In fact, in the recent past, Dr. Chitra from our IRL has reported a pretomanid resistance. So first time we got a pretomanid resistance also in Kerala. So all those resistance patterns can be known, and based on that, we can actually form an individualized treatment regime for this patient, either a BPAL-M or a short or a long regime. We'll come to that later. Now, if rifampicin resistance is not detected, which is a more common scenario, because in Kerala, only 1 to 2% of patients you get a rifampicin resistance. If rifampicin resistance is not detected, you do a first line LPA, mainly for the INH resistance. And if the first line LPA also shows INH resistance, then you actually start the regime for INH resistance. If INH resistance is not there, so that patient has neither rifampicin resistance nor INH resistance, you start the DSTB regime. So ideally, all your patients should undergo this algorithm. But for various reasons, the NAT or the rifampicin resistance testing is being done for majority of patients in Kerala. But the INH resistance testing in the first line LPA, which you see on the right side of your algorithm, is sadly done only in about 1/3 to half of our patients. So that significant percentage of patients do not know the INH resistance status. INH resistance, you should understand, is more common, present to the extent of 7% in Kerala. So that is also very important for us to find out. Now, this is the pediatric algorithm. The presumptive pediatric TB is fever and or cough for more than 2 weeks, loss of weight or failure to gain weight, contact with a known or a suspected case of tuberculosis, in the last 2 years. These are the people who actually you consider as a presumptive child TB. The main change from the previous guideline in this algorithm is that there is no Manto or any kind of testing of that sort in this algorithm developed by Indian Association of Pediatrics and the program together. What you actually have is X-rays, where the X-rays are classified. There, if you look at the document, the pediatric TB document of the program, there are pictures which actually show you what X-ray should be considered as such highly suggestive, which are considered non-specific, and which are when you have a normal. So please look at that document. It's like an atlas giving very good pictures of all the X-ray patterns and all that. So if the X-ray is suggestive of TB, you have to take a sample for NAT, which actually could be expectorated sputum, a gastric aspirate, or could even be a bronchoscopy specimen. So there you look at the NAT, and if the NAT is positive, you confirmed as microbiologically confirmed TB. If the NAT is MTB not detected, and or if the X-ray is not very specific, but after antibiotics also the lesions are persistent, then you look for other site TB involvement. Consider a repeat NAT from a better specimen, or seek a consensus opinion, and you could still be with a NAT negative. You could still consider a diagnosis of clinically diagnosed TB. Of course, if the X-ray is normal, you look for extrapulmonary TB and you may consider other diagnoses. So that is how childhood TB goes. Now, until recently, until 4-5 years back, 5-6 years back, we were treating only TB disease. You know the difference between infection and disease, but of late, we are also treating TB infection. And for the diagnosis of infection, the go-to tests are either a IGRA or a tuberculin skin test until recently. When we started our program for TB preventive therapy, our committee in Kerala decided that the Manto test or the skin test standardized solution has not been available in India for the last 25 years. So we will not use a non-standardized solution, and we opted for the IGRA. Now that means a lot of extra cost for the government, but then we went for the standardized test IGRA for our state. Many states have still gone with the non-standardized tuberculin. Some states in India have a policy of not testing because neither of these tests are available there, and they just rule out active TB and start treating patients for TB infection. Now, any of these tests could be used as per national guidelines, but we were all eagerly waiting for the new test of the CYTB, which is a very specific antigen, very similar to Manto, but the difference is that Manto is a cocktail of various antigens in various proportions, whereas your CYTB has two very specific antigens, ESAT6 and CFP10. So these are the antigens which are used in your IGRA test also. And because it is very specific with those specific antigens, the test is also very specific. Done exactly like your Manto, the solution was widely available in the health service department and also was provided to some private hospital. Of late, there are certain shortages, but still, I mean, that is a go-to test now in our state. We should remember that neither of these tests, IGRA, CYTB, or Manto, should be used for the diagnosis of active TB disease. This is only for TB infection. The treatment of TB infection is different. Do not use it for diagnosing pulmonary TB or extrapulmonary TB or childhood TB. So that is something that should be very clear in our minds. Moving on to the treatment per se. So when we look at the treatment of TB, we have the daily regime which has come to the program with 8 weeks of HRZD followed by 16 weeks of HRE, which is about 24 weeks of treatment, less than 6 months. In fact, 2 weeks, less than 6 months. You are using fixed dose combination, which have certain advantages, also certain disadvantages. And each FDC contains 75 milligram INH to 150 milligram rifampicin, 400 of pyrazinamide, and 275 with ethambutol, given in various weight bands. So you may have to give 2 tablets, 3 tablets, 4 or 5 or 6. And that is how you actually treat the patient. The dosages are different, which has to be known because many people still have a tendency to write some commercial brands for ATT. And when you do that, the dosages will never match. And if there is some side effect or any other problem, people may go to court saying that you gave the wrong dosage and there is no way to fight such a scenario. So we go back to our integrated algorithm and look at how we treat, resistant TB. So the first form of resistant TB is INH resistant TB. What you need is a rifampicin resistance not detected and a INH resistance detected on your first line probe assay. Only such patients, both these conditions should be satisfied to include them in this particular regime. There are no specific exclusion criteria. The regime is usually 6 months of levofloxacin, rifampicin, ethambutol, and pyrazinamide, but you can extend to 9 months in some cases and also extend to 12 months in certain cases. So that is how the regime goes. There is no separate intensive phase or continuation phase. Moving on to multi-drug resistant TB, which is resistance to INH and rifampicin together. There are 3 possible regimes. The go-to or the preferred regime is your BPAL-M regime, which is a new regime where you give 6 months of bedaquiline, pitomandate, linezolid, and moxifloxacin. So this is the go-to regime which came out of the NIX and ZNIX trials and now is being successfully launched. Now with MDR-TB in Kerala, about 50 to 60% of our patients actually go to the BPAL-M regime. Then you have the newer but slightly older, shorter MDR regime, which is a 9 to 11 month regime. This regime also has been slightly modified. Earlier, this regime had ethionamide in the intensive phase, but now you have 2 months of linezolid in the intensive phase. The other intensive phase drugs are given for 4 to 6 months, which is leoflox, clofazimine, pyrazinamide, ethambutol, and high-dose INH. And then bedaquiline is generally given for 6 months or 9 months, and then the continuation phase of 4 drugs of leoflox, clofazimine, pyrazinamide, and ethambutol. Now, that is given in certain cases. You still can give the ethionamide containing older, shorter regime in certain cases where linezolid cannot be given. And of course, the traditional longer MDR regime, which is also oral, is 18 to 20 months regime with 5 drugs in the intensive phase and 4 in the continuation phase. Of course, now WHO, I'm using a wrong terminology because WHO has clarified that The term intensive phase generally should be used only when you have injectables in that phase. So it should be the initial phase and the continuation phase. Anyway, that doesn't really matter. So, like you said, if rifampicin resistance is detected, the first question we ask is if the patient more than 14 years, then you look for whether the patient is eligible for the BPALM regime. The eligibility includes, age more than 14. There should be no resistance to any of the drugs or no exposure to the drugs with proven sensitivity not being there. The QTC should be within the expected range and patient should not be pregnant or lactating. Now, such people, there's also minor exclusion criteria, including deranged LFT, severely deranged RFT, cardiac abnormalities, and severe forms of TB. Such people are excluded. Other than that, everybody should actually get the BPALM regime as a first regime. However, if for some certain reason BPALM regime is not possible, or if the patient is less than 14 years, then you look for eligibility for the shorter regime. For the shorter regime, again, the exclusion include, fluoroquinolone resistance, previous use of drugs without proven, susceptibility, should not be extensive disease, should not, earlier INHA mutation and a KGMOA mutation together on your first was the exclusion, but with now linezolid replacing ethionamide, it is no longer an exclusion. Pregnancy and lactation, again, earlier was an exclusion for the shorter regime, but with your linezolid replacing ethionamide, even those are not an exclusion. But if your patient is excluded from the shorter regime also for some reason, then you have to go for the longer regime. Now, the only regime which can be modified is the longer regime. The BPAL-M regime and the shorter regime, if you need to discontinue any drug, you have to altogether stop the regime and go to this longer regime. Longer regime can be modified generally by the nodal center, and you have to replace drugs when modified. So, the regime has bedaquiline, levoflox, linezolid, cycloserine, and clofazimine. If any of these drugs cannot be used due to resistance or due to some adverse effects or some other comorbidity, then you have to start replacing based on whether that drug can be used in the order of delamanid, amikacin, pyrazinamide, ethionamide, PAS, ethambutol, and imipenem. Now we covered the basics, and in the next 20 minutes or so, we'll go ahead with what is to be done more than this routine that we are actually doing. So the strategy, as you all know, has been evolving by starting with the DOT strategy. By 2006 to 2015, you had the Stop TB strategy. And now, since 2016 onwards, we have this new strategy called the NTB strategy, which is very ambitious and which aims to end TB. So there are various targets, milestones, including those for 2025, 2030, 2035. By 2035, you want to reduce mortality by 95%, reduce incidence by 90%. And throughout this period, there should be zero catastrophic costs. Catastrophic costs, I'm not really dealing with in detail in this presentation, but you should remember that there could still be catastrophic expenditure despite us giving the drugs and medications and everything free. So, the other patient that I was discussing earlier, TB spine, he underwent MRI. He was suggested that he would go to Coimbatore and do a spine surgery, or how fortunately he came to Thrissur and did it. So he did not expend money. But if that patient had gone to Coimbatore for a surgery, such things, end up with the patient losing a lot of money and they're going for catastrophic expenditure. But the main things that we are looking for is, reducing mortality and reducing incidence. If you look at it, the program has evolved from the DOTS program to the, to the revised National TB program and the control program to the National TB Elimination Program, or the NTEP. Now, to achieve what the NTEP wants or the NTB strategy wants, you need to do a lot of new things. Currently, what you're doing will not be enough. You need new tests, you need universal health coverage, you need to cover for TB preventive therapy, you need to have new point of care tests, and so many other things have the active case finding, and all is needed to actually reach these targets. Now, for our point of view, to reach the targets, one, for reducing death, what you need is early detection of cases, early initiation of the right treatment. So if it is a MDR TB, MDR treatment. If it's INH resistant TB, the treatment for INH resistance, or for DSTB, the DSTB regime. Ensuring that the patient takes the treatment regularly and completely. As far as possible, DOT should be there. We should not assume that with the NTEP, DOT is gone, but you have to ensure compliance, and also differentiated TB care, which we will be discussing later. Now, for reducing incidence, the major factors are early detection and initiation of treatment again, so that prevents the spread of disease. Again, we saw X-ray earlier where treatment initiation was, detection was delayed. So for 3 months, the patient was continuing to infect other people. You have multiple examples like that. TB preventive therapy is a good way of reducing incidence, and you have to address other factors which lead the infection progressing to disease, which include nutrition, HIV, diabetes, smoking, alcoholism, and all. When I say that, often people think that you give nutrition to TB patients, but to reduce incidence, the nutrition is not for the TB patients. The nutrition is for people who are at risk of developing TB, but who have not yet developed TB. So if you give nutrition to such people, you can actually reduce the incidence. Now, of course, for zero catastrophic cause, early treatment, early initiation of treatment, early diagnosis leads to lesser complication and lesser cost to patients, and avoiding complications in such patients is what works. So, and the government supporting various forms of care also adds to that. Okay, so what is new, which we have discussed again in the past, is that the spectrum of the disease has changed. Earlier, we used to think of an uninfected person becoming latent TB, then active TB, and leading to treatment outcome, either success or death. But now the latent TB has been divided into two, the proved latent TB and incipient TB. Incipient TB is where the bacteria inside the body have not manifested as disease, cannot be picked up on any investigation, but the bacteria are in a multiplying phase. Whereas the true latent TB, the bacteria are totally quiet. We don't know whether they will multiply sometime in the future. So that is very difficult to differentiate with the current tests that we have. Then active TB also, they have classified as subclinical TB and proper active TB. Subclinical TB now, the terminology by WHO is asymptomatic TB. Now, such people can either be truly asymptomatic, may not have symptoms at all, or they may actually have mild symptoms which they are not recognizing as symptoms. So both these things are there. In that context, when we look at our TB prevalence study, which was actually to determine the prevalence, so we should all be proud that Kerala has the least burden of TB in the country when you compare with Delhi, Uttar Pradesh, and all, which have more than 500 per lakh of TB cases. We have more like 100 cases per lakh of microbiology confirmed pulmonary TB. And infection rates also 32% in India and about 20% in Kerala. So that may be much better off than India. But then there are certain other problems to consider. One is the health-seeking behavior. So if you look at the national perspective overall, only about 36% of patients in the prevalence survey who had symptoms of TB had approached a doctor. So remaining, 64% had not approached a doctor despite having symptoms. And you look at states closely in alphabetic order, so you can see that, for example, Haryana, only 12% of patients with the typical symptoms of TB had actually approached a doctor. That percentage, as expected, is higher in Kerala at 54%. So among all states in Kerala, Kerala has the highest percentage of presumptive TB approaching a doctor. But the problem is that even in Kerala, only 54% of patients approached a doctor, which means that 46% of patients in Kerala who had cough more than 2 weeks or fever more than 2 weeks or loss of weight and all had not approached a doctor. The second major finding from the TB prevalence study was that about 42% of patients did not have any symptoms at all. They only had X-ray lesions, and that is why their TB was diagnosed in the prevalence study. So that is a very important finding, because generally we pick up patients after they develop symptoms. But if that happens and if you miss these asymptomatic TB, continuous spread of TB will occur in the community and elimination will not happen. So our previous approach during the revised National TB Control Program era was that you actually identify persons with symptoms suggestive of TB, the logic being that most patients will have symptoms, focus on patients coming to hospitals, active case finding in hospital setup, because most patients will seek care for their symptoms, and most infectious patients can be picked up on smear microscopy. So smear microscopy should be the leading test in the program. But now we know that there is something called subclinical or asymptomatic TB, and almost 50% of TB patients do not have symptoms. So if you wait for symptoms, you will miss 50% of the TB. They will still spread the TB. The second point, of course, is challenged by the fact that even patients with symptoms of TB do not come to hospital, to the tune of 60% in India, 64% in fact in India, and 46% even in Kerala, which means that again, if you wait that symptomatics will come to the hospital, they may come very late to us. And the third issue also, the fact that asymptomatic TB, smear negative TB, can also spread TB. So, you can't base your diagnosis on microscopy thinking that they will be the more infectious. You'll have to take care of all forms of TB. So we think of missed cases. So, if you saw the TB prevalence study report, which I projected earlier, Kerala had a, prevalence of microbiologically confirmed TB of 115 per lakh, but actual notification in Kerala is somewhere around 35 per lakh. So there was a huge gap between the estimated prevalence in the study and the notified cases in many states of India and India as a whole. So you have to think in terms of why we are missing cases of TB. So first, the subset would actually include the actual TB cases. Out of it, generally, as of now, we are screening the symptomatic people. So when you look at that, there itself, you will miss a significant chunk of patients. Then among the symptomatics, you generally, diagnose in people who come to doctors. So many of them are sitting with their symptoms, not coming to a doctor. And then many have to reach the proper diagnostic center, usually in the government, to actually for diagnosis and all. So that also happens. And then the doctor has to think of TB. So we saw that first case where the patient actually had come to one of our primary health centers, but the diagnosis was not made. So that diagnosis has to be made as well. So at each level, you can actually increase these numbers by, for example, asymptomatic TB can be picked up by X-ray screening. Health-seeking behavior can be improved by IEC and active case finding. Private sector involvement in the program can be strengthened so that they don't have to come to the government all the time. And training of doctors and monitoring of performance can actually improve the cases being diagnosed. So all of these can be tackled. Another recent study, which is yet to be published by Matthew and all of us, looks at the health-seeking behavior of patients in Kerala. So you can look at this very complicated chart, which actually tells you that patients on all sectors, whether it's coastal, rural, tribal, or urban, they go to government, then they go to private, then they go to government, then they again go to private. So they go between various groups. And many of the patients, generally patients at the first consultation is almost 50-50 between government and private, but then the government proportion actually slowly increases as the number of consultation increase. In the government, certain patients had to undergo 6 different consultations before a TB could be diagnosed. Of course, many of them were diagnosed early, but a smaller proportion of patients had to wait for 6 consultations for diagnosis. In the private, they had to wait for 5 consultations for diagnosis. So even after 5 consultations, some of the patients had to go to the government for a 6 consultation for diagnosis, which actually means that people do come to our hospitals, but we are actually missing TB cases and people are running from post to pillar for diagnosis of such a simple disease like TB. Also, the fact that we discuss a lot on X-rays, need of X-rays and all that. But then this young girl, engineering college student from Adur, who had come to Trivandrum, the lesions were there on X-ray. Now, if the X-ray lesions were missed, CT was taken and the CT also showed upper lobe lesion. The patient was referred from medicine to pulmonary medicine, telling that it may be TB, please go for treatment. The girl's mother decided that my daughter will not have TB and went home. But the point I'm making is that the earlier era, maybe 20 years back, the moment you see a lesion like this in the upper lobe, you actually start ATT immediately. But of late, we are losing our confidence to start treatment on radiological basis because of medical legal litigation and things like that. But the result of that is that this young girl continued to go to engineering college, would have infected a lot of her students in that college, and later she came with extensive cavitary disease, which was unilateral earlier, now became bilateral. The problem, there are 2 problems. One, she would have spread the disease, and second one, now that she has such extensive disease, even if we treat her successfully, she will end up with sequelae of TB. So it's a sad state of affairs. It should not have happened in such a patient. So we need X-rays, and you have X-ray vans like this. This man, the tall man, is the Coimbatore district TB officer, and he himself designed these, beautiful looking vans for Tamil Nadu, reducing the cost from 1 crore to somewhere around 50 lakhs. So Tamil Nadu has 50 such vans. Unfortunately, we don't have any in Kerala. He had one in between. So that is the thing. And other than van, even short, less costly options are these portable X-rays. So, the X-ray, the plate, which is a digital reading plate, all can be packed on a backpack and the person can go in a 2-wheeler and take X-rays in any remote area. And these images can be transferred both from the van and from these portable X-ray units via Wi-Fi to AI, computer-aided diagnosis software and diagnosis also can be made. At least abnormalities can be found. So computer-aided diagnosis is coming up in a big way. Certain reading softwares are there. QRAI, which I'm showing here, is an Indian-developed software, which is one of the leading one in the world now. Our old WHO consultant, Malayali, is actually working there, Shibu Vijayan. And the company is also owned by a Malayali. If you have time and if you're inclined to technology, go to QRAI. You can register for 2 weeks and read X-rays for free. But later, of course, you'll have to pay for it. So, just try it out just for fun to find out how it works. Now, moving back to our traditional tests, which we had discussed in the algorithm. So, you have the Gene Expert, the TrueNAT, which are common nucleic acid amplification tests. The XDR cartridge has been endorsed by the program, will give you very fast diagnosis of, fluoroquinolone, second-line injectable enthionamide. But there are certain technological problems which does not allow the technology to be implemented. Line probe assay is available in the 2 labs, both in Trivandrum and Kozhikode in Kerala, which can actually, it's a slightly, more complicated test, but it can give you line probe assay can give you INH rifampicin and ethionamide, and line probe assay can give you fluoroquinolone second-line injectable. Solid culture, liquid culture, again available in our 2 labs in Trivandrum and Kozhikode. So all these technologies are available. Very costly things can be given free of cost to our patients. But that is not the end of it. You have more technologies coming in, more complicated NATs, which actually help you to diagnose INH and rifampicin. This is something that we all wanted. Here, right now, you're doing one test for rifampicin, another one for INH, and the INH test doesn't get done. So if you have these technologies which cover both INH and rifampicin together, then obviously our pickup of INH resistant TB will also increase. The LAM and urinary LAMP test has come. The TB LAMP has come. So next generation sequencing has come. Many countries have implemented this. For example, Indonesia has implemented targeted next generation sequencing in a big way. So maybe these will come to Kerala and India also very soon. WHO has come out with newer recommendations. Time doesn't permit me to go into that, but I'll just show recommendations 7, 8, and 9, which have not come to India. Please do not take this as our national policy. But if you look at it for children and adults, for who are HIV positive, they say that testing of the sputum alone is not enough. With the respiratory specimen, you also do a lateral flow LAM in the urinary specimen. In a HIV negative child, in addition to the induced sputum or bronchoscopy aspirate and all that, do a sputum sample also concurrently. So test 2 different samples. And in a HIV positive child, do concurrent testing with a respiratory specimen, a stool specimen, and a lateral flow LAM. 3 different tests can be done for the single child to actually increase the yield of tuberculosis. This has not yet come to India, but this is a WHO current recommendation, and sooner or later it may also come to India also. I'll skip all this because of shortage of time. Newer technologies are also coming to Kerala. For example, this PethoDetect assay, which has the test kit has reached the intermediate reference lab at Trivandrum, but yet to be installed. It can give you TB diagnosis and resistance to INH and rifampicin in 2 hours. This is what I said we need, and this test is currently already available, but the lab has to start doing it. So we'll move to the last part of our presentation in the next 10 minutes or so. So we'll discuss differentiated care for TB and why and how this is actually needed. So like we said, the strategy has moved and we are looking at very ambitious, we already discussed this part of it. Now, certain things need to be done in addition to actually diagnosing and treating patients. So one, you can prevent TB by looking at the various vulnerabilities. This was the initial analysis done, which looked at the 22 high burden countries, but then we have done our own analysis. Rakesh and team have done their own analysis in Kerala, which showed that in Kerala, the factors associated with progression of infection to disease are undernutrition, close contact with a TB patient, diabetes, tobacco, COPD, and so on. So these factors have to be given importance to find out TB cases, vulnerable cases early, to diagnose TB early. So based on that, Kerala started a strategy of vulnerability mapping, where every district was covered. About 2.7 crore people were screened, and various vulnerabilities were found out. And based on the number of vulnerabilities, high vulnerability areas, low vulnerability areas were screened. This is Alappuzha district, where you can see the panchayats which have high vulnerability, which have medium vulnerability, low, and all that. So this kind of mapping was done. What was expected is that first we will do the vulnerability mapping, then you will do an active case surveillance. So every 3 months, these highly vulnerable people who are found in the vulnerability mapping, somebody health worker would visit their households every 3 months and screen them for TB and also increase the private sector involvement. Of course, that did not happen to the extent that we wanted. And then we wanted to go to the next phase of vulnerability reduction and also latent TB treatment in these vulnerable groups. But of course, the strategy somewhere has got diluted and we have not reached that level. When we look internationally also, you have various targets and what did we achieve. So if you look at the target versus achievement, we have not done well internationally. So if you look at it, you're looking at a 50% reduction in TB by 2025, you reached only 12% reduction. You are expecting a 75% reduction in deaths by 2025, you reduce only by 29%. You are looking at zero catastrophic cost, but you still about half the patients in the world have catastrophic expenditure, which actually means that we have not done well on the world scale. Whereas India has, got appreciation all over the world because India has done better than many other countries in the world. So we had a 17% decline in TB, which is, more than the world decline of 12%, slightly more, but maybe by 2025 it will become even more, maybe 20%, but more than the world anyway. Missing cases have reduced substantially, and we have improvement in treatment success rates, particularly for drug-resistant TB. This comparison between 2020 and 2022, if you have a longer comparison, we started MDR treatment in 2008. So if you compare from 2012 onwards, you can see that, earlier we had only about less than 50% success, which actually increased to 66% for MDR TB, 62% for, XDR TB by 2019. And by 2024, you can see that has actually increased to 75% success in MDR TB, which was something unimaginable when we started MDR management in India. So Kerala has even major achievements, So if you look at the notification rates from the report which I took, so we had 66 per lakh case detection, reduced to 57 per lakh by 2025. But then that is not the only 14% reduction, but the reduction is projected as 6% per year with almost a 40% reduction, because these are the notified cases, but there are in that past era, you had cases which are not notified also. So you had private sector cases which are not being notified. Now today, almost all cases, both in the government and private, are notified. So at this phase in 2015, we have 40% of cases in the private sector, many of them not notified. Now we have only around 15% of the cases in the private sector. 25% of cases in the private sector. And most of them are notified. So, our number reduction has been much more than what is the reduction in the notified group. We have a epidemiological shift of TB patients becoming older, which indicates that a positive epidemiological shift. And we have various, success stories, including high success rates for MDR, private sector mediology involvement, including the STEP strategy. We have difficult treat clinics conducted regularly with good results. Our lower numbers, for example, if you are in Mumbai, each nodal center will have about 1,500 cases to treat, whereas in Kerala, one nodal center has only around 150, 100 cases. So it's easier for us to manage because our success has resulted in lower numbers. And the commitment from the government, the local government, and people's movement is quite high. So, but moving on from the positive examples, including the local government involvement, how well we did during the COVID era, there are problems. And the major problem in Kerala has been the increasing death rate. So for long, our death rate was around 4%, 5% and all that. If it ever increased more than 5%, we used to get huge firing from the health secretary down to the DHS, down to the district medical officer, down to the PHCMO. So our mortality had to be contained within 5%. So 4-5% was the maximum allowed. So that was going like that till 2019. After which suddenly after COVID and later, the mortality rate started increasing. And now for the first time, we have crossed 10%. 10% mortality is unimaginable. And one cannot understand why 10% of TB patients on treatment in Kerala should die of TB. So, that is a major, major concern. And that leads to the need for differentiated care. That is what we all mentioned about differentiated care for TB. So we have this differentiated care document, revised document from 2025. You could actually download it from the website. Now, this is one document where my name is there, but my contribution has been minimal because we have not been doing differentiated care well in Kerala. Any other document being formed in India, from Kerala would have a lot of contribution. In fact, they would come back and say, Sanjeev, केरला की बात मत कहो, जो केरला में होता है कहीं इंडिया में और नहीं हो सकता, मीनिंग दैट what you do in Kerala cannot be replicated in other states, but this is one area where other states have done it, but we have not been able to do to that extent. Differentiated care actually means that you address the challenges, through a framework related to high mortality through patient-centric, tiered healthcare approach that prioritizes high-risk population and ensure targeted, efficient, and equitable care. So the core objectives are to have early identification of high-risk individuals, to prevent complications and reduce early deaths, which actually deaths in TB, almost 70% are early deaths. So those can actually be prevented by picking up these things early. Now, the document also talks of how deaths occur in TB patients. So if you look at it, if you look at the program document, among the 27 lakh patients we start on treatment, only around 85,000 die. And if this pink in the round in the back is actually the actual TB deaths. So, many of the TB deaths which are notified in the program are not TB deaths actually. They have other causes of death. But then you have to know that a high chunk of patients are on treatment outside of Nikshay. They die. People who are untreated die. People who are undiagnosed die. People who have completed treatment die. People who interrupt treatment die. So all these categories have to be considered. Only then the 3 lakh deaths in our country can be explained. So it's a mixed bag of things. It's not just our patients on treatment. So you need early treatment diagnosis, active case finding, asymptomatic case finding, differentiated care, comprehensive private sector involvement, follow up using, ensuring that there is no loss to follow up, and also post-treatment deaths can be prevented by post-treatment care. Now we have also done, Karthika and the Alapura team actually did, my close friend and classmate, Karthika and the Alapura team have done a study which looked at cause of death in Alapura. And they found that 40% of patients die of TB alone. But the remaining have other comorbidities which could have significantly contributed to their death, including 18% MI, cancer, stroke, COPD, bronchiectasis, and other causes and all. So that is there. But it should not become an excuse. So, I remember a meeting where the health secretary was present and all our DTOs were presenting. So the district TB officers are all saying, the patient died of diabetes, patient died of COPD, did not die of TB. So implying that, please don't blame us. Patient died of other causes. So then the health secretary turned to me and said, Sanjeev, you implemented a program called SHWAS, and now I am understanding that our doctors are unable to treat COPD. Suppose they have TB and COPD. Why can't the COPD be treated and the TB death be prevented? If they have TB and diabetes, why can't they, treat the diabetes and prevent the death? If there's a suicide, patient is on DOT, why didn't you prevent the suicide? So it should not become an excuse. These are all factors which can be addressed. So our neighboring state of Tamil Nadu actually went ahead and implemented a differentiated care model for the first time. And that became a huge success. Their screening criteria was very simple. BMI less than 14 or BMI less than 16 with leg swelling, increased respiratory rate, low oxygen saturation, and inability to stand. So any of these being present, you actually bring the patient for differentiated care. So they also looked at how much percentage is missed at every level. So identify the ones who need differentiated care, do a comprehensive evaluation next level, give them inpatient care. So about 90% or, about 85-90% of patients need IP care among this group. So, which actually means that if we implemented this in Kerala, about 1,500 to 2,000 patients would need hospitalized care to provide differentiated care. Only then we will be able to save those 2,000 deaths or so, which actually occur in Kerala. So that is the major challenge for us. So Tamil Nadu showed that they could actually reduce significantly the deaths, 12% reduced to 7.8% in Dharmapuri, reduced in Karur, reduced in Villupuram. So, many of the districts successfully reduced their mortality rate by implementing the differentiated care. Now, the national document, which I showed you earlier, has a slightly different classification of people who need differentiated care, the red flag criteria, which include patients who confined to bed, breathlessness, severe chest pain, altered sensorium, hemoptysis, vomiting, diarrhea, and any adverse drug effects. So these are also added in our national document. But this is not the only way to reduce death. A very good study called the Ration study has come, which was implemented in Jharkhand. And this study also showed that, by giving good nutrition to TB patients, which is a low cost, good nutrition, very balanced diet to patients, they could significantly reduce mortality and improve success. And also the family members were provided nutrition and they could significantly bring down the incidence of TB in the family members. So this has been quoted all over the world now and has become a model from India. Now, having said all this, having successful models, why is Kerala not able to do it? I think the major step is that the first step for differentiated care is identification of dedicated airborne infection control compliant hospital beds for TB. So Kerala had a rich history of hospitalized care for TB. Many of the district TB centers, for example, Ernakulam or Kottayam or Manjeri and all, they had TB beds. I worked in a taluk hospital in Chalakudi where I had 14 beds when I worked in the health service department. All the 14 beds used to cater for TB patients in Chalakudi, particularly the tribal patients from Vetlapara and Malakapara and all that. So, that was there in Kerala. But today, Kerala, we sadly find that there are no hospital beds for TB. The only places where you can hospitalize TB patients are Trivandrum Medical College, that is Pulmonary Hospital, Karnagapalli, Mulanganathukav in Thrissur, and Pariyaram. So these are the only places. Whereas some other places, 2 beds are supposedly available, they may or may not be available. So then you have to identify the beds and then triage that, patient from PHC A will go to this hospital for hospitalized care, PHC B will go here. So all those triaging and reference systems have to be put in place for implementation of differentiated care. And when we start, our factors may be different. Ours may be older age, diabetes, we have about 35% of our patients having diabetes. COPD is quite common in Kerala. We have a high chunk of homeless patients or patients with no caregivers, and we have tribal population and many other special populations as well. So all these have to be strategized, and we need a good local strategy for differentiated care with the infrastructure in place. Only then we'll be able to successfully implement it. So I'll conclude by saying that, we have had rapid advances in diagnostic technology for TB, and even more tests are in the pipeline. All these diagnostic tests are available free of cost to our patients. Newer treatment regimes have increased the success rates for TB, both drug sensitive and drug resistant TB. Kerala has had multiple successes, but death rates increasing is a major area of concern. You have newer insight in TB epidemiology, which have changed the way we approach TB diagnosis and treatment, and differentiated care and other models have successfully shown how you can actually reduce mortality in TB. It's only a matter of us creating the right infrastructure, and implementing it in our school. Thank you. Thank you for the patient listening. I'm open to comments and questions.